CSEP is a public policy think tank with research focused on a range of issues, including growth, finance and development, energy and climate change, and foreign policy. Very recently, CSEP initiated a work program on human development with a specific focus on health policy. The program aims at analyzing health policy and systems from the perspective of improved health outcomes, as also reduced financial risk associated with accessing healthcare. As part of this work, in the last few months, we have been engaged in distilling insights from the design and implementation of health systems across countries, with a view to understanding how different mechanisms of governance, financing, organization contributes to building resilient health systems. The papers on 6-country system, which is what we're looking at, will be up on our website soon, so do look out for that space. Based on this analytical work, we have now initiated a dialogue series, which is basically focusing on different aspects of the health ecosystem and discussing that across different countries. And today, our dialogue is focused on primary healthcare. In case anybody is asking why primary healthcare, there is a global consensus now that universal health coverage can only be achieved on the foundation of a strong primary care system. And the last 2.5 years or a little more have underscored that, as the pandemic made very clear the importance of building a strong primary healthcare system. I want to talk a little bit about India and where we are on primary healthcare. India has for long underscored the criticality of primary care. It is not something that the country is waking up to now. If we look at the architects of NRHM, which is the National Rural Health Mission, as far back as 2005, even then, primary care was the center of India's health initiatives through NRHM. In fact, the link between the health system and communities was recognized through the ASHA model. Today, India has a very elaborate network of government primary healthcare facilities, both in rural and urban areas. But they have for long delivered on a narrow range of services, and for that reason have been somewhat underutilized. But that has been recognized, and if I can call it that, a sort of second wave of primary care reforms were initiated in the country in the last few years. The vision for these reforms is very holistic. It does focus on expanding preventive and promotive services, in addition to the curative services which were already there. There has been a change in the approach to service delivery, moving from merely routine curative care to more of community engagement and leveraging a variety of other cadre providers. The reforms move away from a medicalized workforce to community health officers. And in fact, this approach has been made institutional through the legal status, through their legal status, which is included in the National Medical Commission Act. The Act, in fact, empowers non-physician providers to prescribe a limited range of medicines. At the same time, there are states such as Assam and Chhattisgarh, which have actually adopted innovative approaches of leveraging a range of providers to work on primary care. Part of the vision has also been leveraging digital health and technology-enabled family healthcare, digitization of records. All of this has been started. And of course, infrastructure is being expanded through India's health infrastructure mission. So the point is that there has been enormous movement in India, as well as in multiple other countries. And so it seems like a very opportune time to discuss the insights that are emerging from all of these experiences. The dialogue today is a sharing of experiences across countries, focused on 3 key aspects. We will look at organizing primary care, we will look at financing care, and we will look at that tricky issue of human resources. The focus of today's dialogue is on 3 countries, Brazil, Turkey, and India. However, That should not stop our speakers from actually referring to insights from other countries as well. Now, we're honored, really honored to have a stellar panel with us for this dialogue. First, the event is chaired by Dr. Vinod Paul, a globally respected medical scientist and member NITI Aayog, leading on health, nutrition, and education. Dr. Paul has played a pivotal role in the design of several key reforms in the country, including those aimed at primary care. And of course, he's led numerous committees and task forces. Our discussants today for Country Insights include Ms. Sujata Rao, who's former Secretary, Health, Government of India. She spent 20 years in health during her professional career with the government, both at the state and country levels, national level. She has represented India on numerous global boards and has been a founding member of key institutions. Professor Rifat Atun is Professor Global Health Systems at Harvard School of Public Health and the Director of Health Systems Innovations Lab. His work spans multiple countries, and in addition to a large body of research, he has advised numerous countries on health system. Professor Erno Herzai has been Secretary Primary Health for the government of Brazil. In this role, he led the primary care reforms in Brazil. He's currently professor at the medical school at Federal University of Rio Grande do Sul, and also has a large body of research. We will now welcome all of you and thank you once again for taking the time out to be part of this dialogue. We will start with the chair's opening remarks, and we will then have 3 rounds of discussion focusing on 3 issues or questions, whatever you want to call them, followed by audience questions from the audience. So with that, I would request Dr. Paul to share his opening remarks. Dr. Paul, thank you once again for joining us, and over to you.
Thank you very much, Sandhya. Good evening, good afternoon. Respected Madam Sujata Rao, Rifat Atun Sir, Dr. Erno Horyam, and the participants of today's meeting, today's discussion. I'm grateful to Sandhya for providing me this opportunity to be able to listen to stalwarts, listen to experts, world leaders in the sphere of health sector in general, but even more so in the very, very important and core area of primary health care. So thank you for the opportunity. You have already set the stage by articulating some initiatives, the key initiatives taken by the government of India in catapulting primary health care to a very next level, to the very next level. Primary care has been a focus ever since India gained independence. The early focus was on diseases such as smallpox, shall we say, other communicable diseases, cholera. Family planning came up as a very important area in the 60s and so on. And then slowly but surely, the scope of primary health care improved with more focus on children with diarrheal disease, immunization program, pneumonia, and so on, and of course, on antenatal checks and maternal care, postpartum care, and so on. But I think the current commitment to primary health care is remarkable. And the origin of the current initiatives goes back to the exercise undertaken in 2015, 2016 in articulating the national health policy. Ultimately, the national health policy document was released in 2017, but a lot of discussion took place after the new government came in 2014 under the leadership of the Honorable Prime Minister Modi. During those discussions and the churning that took place at that point in time, the strategic shift from limited primary health care to comprehensive primary health care emerged, that contours emerged. And at that time, a lot of listening in regard to the models in other countries, apart from our own experience and NGO experience, was all put together and it came together. I may also mention that the high-level expert group 2011 report by the Planning Commission, the organization, the predecessor organization where I am sitting here, also helped sharpening the debate around the emerging contours, the paradigm of primary health care. So come 2017, we have a national health policy, which lays a very sharp focus on primary health care. We are committed to provide 2/3 of the government health budget to primary health care. And we moved from what we have been seeing as a limited primary health care to comprehensive primary health care. When we say limited, what we meant was that it was focused on maternal child health and newborn health, some communicable diseases. It was evident that it must enlarge fully to encompass non-communicable diseases, care of the elderly, mental health, eye care, ENT, huge unmet agenda, palliative care, and so on and so forth. So at least this was all put on the table. So we need to move in that direction, and we need to find the ways and means to do so. And a report which is connected to the exercise of developing the policy was very, very useful, extremely useful. And to me, this set the stage for them pushing for action based on very, very, very important thoughts that came around from the comprehensive primary healthcare report, was also the HLEG report that I was referring to. From 2014 onwards, there is a transformation. Our existing system in the rural areas, to be specific, is to have a sub-center or sub-health center covering about 5,000 to 6,000 population, and a primary health center covering about 30,000 population, and then so on. What was then designed, the upgraded design encompassed that the sub-center will now be called as a sub-center, but health and wellness center, okay, at sub-center. And the primary health center will also be called a health and wellness center, in bracket, primary health center. The thinking was that it should be now the platform for targeting all the primary care needs, primary care services, step by step, and also then to have outreach hub from here, reaching out into the community for, shall we say, public health action and disease prevention action and disease control action, with these health and wellness centers serving as the nodes and the hubs and the nodal centers. In 2018, a decision was taken in the broad rubric of universal health coverage to launch 2 interlinked missions. This is early 2018. And these 2 missions were under the overarching name of Ayushman Bharat. That means long live India, Ayushman Bharat. It had 2 pillars to begin with. It had a pillar of comprehensive primary health care through these health and wellness centers. So it was health and wellness center, and loaded onto this is the paradigm of comprehensive primary health care. And the other pillar was the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the health assurance scheme for secondary and tertiary care for 500 million people. Later, to this family of Ayushman Bharat, we have added digital mission and health infrastructure mission and so on. But at that time, these were the 2 missions launched. In April, the primary healthcare mission, and in September, the health assurance mission. So a big change happened starting 2018. The vision for comprehensive primary healthcare was that we shall transform 150,000 sub-centers or primary health centers, obviously many more sub-centers, into health and wellness centers. And Sandhya referred to the structure of, the human resources for the health and wellness center, which at the sub-center level will now be manned by a new health worker, new provider. And this is a very fundamental shift because such a provider did not exist. We had the ASHA workers, the community workers, or community mobilizers, and we had auxiliary nurse midwives primarily focused on maternal and child care. Come this proposal or come this model, and we have what she referred to as a community health officer, who today typically is a graduate well-trained, registered nurse. So India has now put close to 94,000, 95,000, almost 100,000 nurses in the rural heartland of India, and we are building the urban component of this also, and I'll come to that very briefly toward the end. So a new worker, but with that comes the idea of more expanded comprehensive primary health care, in which apart from the child care and communicable disease, which was going on, and family planning, have now been added the strengthened component of non-communicable disease, treatment of hypertension, screening and treatment of diabetes, and then screening for cancer. I'll come to the numbers in a very short while. And then moving on to perhaps other non-communicable diseases, such as detecting the non-alcoholic fatty liver as a precursor of cirrhosis, for example. What we have not done so far is to add additional components such as mental health. We have to be adding at some point in time care of the elderly. We have to be also looking at eye care and ENT care. So those components will be now layered one by one on this platform that has been developed. It doesn't mean all those have to be delivered by the same person. For example, for dental check, there could be a periodic visit by a dentist. For eye check, there could be a periodic visit, but those services will get layered. Today, as we stand, we have completed the task of operationalizing 120,000 of the 150,000 that we have targeted for. These health and wellness centers are functional. End of this year, the target of 150,000 health and wellness center upgradation, so a functional transformation will be completed, and we are on track. I'm happy to add here that 1 billion footfalls have been recorded in the last 4 years and 3 to 4 months in all the established health and wellness centers. Total hypertension screenings are 230 million, and those who have hypertension, they are put on treatment. I'll come to that in a minute. Total diabetes screened 186 million, total oral cancer screening 124 million. Each health and wellness center at the sub-center level provides 105 free drugs. Each health and wellness center at primary health center provides 172 free drugs. A sub-center health and wellness center provides 14 diagnostic tests, and the PSC one provides 63 diagnostic tests. So it's comprehensive in terms of the free drug supply as well as the diagnostics, and more of this could come. As I said, the new worker has been put in place. There is also the digital family, shall we say, folder or digital health records. This will be entry for digital health records also. And when you go to these places, these are of course additional services, but they're also new buildings and a new paradigm where yoga exercises and wellness activities also happen. So there is a transformation in the making in a very big way. We are extending this to urban areas. It's a bit slow, but then in this part of our journey, this will gain acceleration. A special, apart from the normal budget, the 15th Finance Commission, which has also provided additional budget to the third layer of our the local self bodies, the Panchayati Raj system, both and urban, have provided injection of huge resource, something to the tune of $10 billion equivalent over 5 years to strengthen the primary healthcare in the urban and rural areas. So a clear, proud moment and a proud scheme that the government has been implementing. And we believe this will, in a very big way, will be a precursor for change. Ultimate vision would be perhaps a family health doctor sitting in these health and wellness centers tomorrow. If there's a need for additional workers to take care of additional responsibilities, that would also happen. But in consonance with this, I also want to make one last point. There are other initiatives on promoting health. Primary healthcare also emphasizes health promotion. And there, let's not forget that India has built 110 million toilets in rural areas. 110 million toilets since 2014. India has provided 94 million cooking gas connections to rural households. 94 million. And India is now in a mission of providing safe quality water to rural households. Today, 52.5% of rural households, that accounts to 100 million rural households, have potable water in their homes. This mission was started only in 2019 only, when this proportion was 17%. It has now moved to 52.5%. And in this period, you can see a tremendous increase in water supply. So water, sanitation, toilets, clean air, cooking environment for the family are at least three major examples where life in terms of prevention of disease and wellness would improve. And just to also add that there is a very major community-led movement for promoting yoga in our day-to-day life. I'll stop here. Be happy to take the discussion forward. But just to say, in conclusion, that India's commitment to taking primary health, to having a very solid, comprehensive, resilient, sustained primary health care is a dharma. It is a given. We are committed to strengthen it. We have made very major progress in the last 4 years, but that's only the beginning. So much more needs to be done. And we have seen, last but not the least, that the pandemic response and vaccination coverage, what we achieved was through the primary healthcare workers, the grassroots workers, and the system that is now getting strengthened by the day. I'll stop here, Sandhya, and we'll pick up threads as the discussion picks up pace. Thank you very much for the opportunity.
Thank you, Dr. Paul. That was amazing. Thank you for framing the discussion and sharing with all our participants all that India has done and the commitment and the distance it's been traveled, both in terms of the thinking and the action. I think India's vision is very, very holistic. And like I said, at the risk of repeating myself, this is an opportune time for different countries to come together and discuss their experiences. So let's jump into the discussion now. The first sort of question or area of discussion is around organization and governance. And an effective, I think everybody knows that an effective preventive, promotive, and curative system has to go beyond sporadic engagement with the system, with citizens, and the system has to take responsibility for promotion of population health. In fact, Dr. Paul's last point referred to population health, and from primary care, we see very often what falls through the cracks is the preventive and the promotive aspect of it. In a sense, this means that the system needs to cater to those who are not on their own attending health facilities. Now, my question therefore is, what is the feasibility and what is the approach of transitioning a system from a reactive to a proactive one? By reactive, I mean people coming to a health facility when they're sick. By proactive, I mean citizens actually taking responsibility for the health of community, whether they're sick or not. And implicit in this question is also, what is the pathway? What are some of the path dependencies in moving from a reactive to a proactive one? I'd like to start with Anu. Anu, if you could talk about Brazil's experiences. Brazil has impaneled community groups, and there is a sense that impaneling community groups is a key element of being able to address population health. So my question to you is, how critical is that from Brazil's experience? And also, if you could talk about the role of decentralization. Both Brazil and Turkey are very, sorry, not Turkey. Brazil is a very decentralized system. So what role has that played in terms of addressing population health? And what were the enablers for empanelment? Over to you, Arnav. About 5-7 minutes.
Okay. Good evening and good morning for everybody. I would like to begin. Thank you, Sandia and the Center for Social and Economic Progress for this invitation. I'm very proud to talk to you about the Brazilian experiences on primary care. Before starting, I think it's important to briefly describe the Brazilian health system, very briefly. Brazil has 210 million inhabitants and a tax-funded universal healthcare system. About 30 million people also have private, out-of-pocket health coverage, but with some degree of public tax incentives. For about 180 million people, the SUS is the only health system. And SUS, the name of our health national system, has as a fundamental principles universality, comprehensiveness, and equity. And these three principles should be in equilibrium, and it's not a very easy task to equilibrate these three sometimes contradictory principles. SUS is organized on a municipal basis. Municipalities are responsible for providing health services from primary care to hospital care. Obviously, not all municipalities offer all services, but intermunicipal arrangements are agreed through the role of the states, the 27 states we have in Brazil, and the federal government to make the flow of the people seeking care from primary care to hospital care easier. It's the obligation of all municipalities, however, to provide primary health care services. This is offered in Brazil through the family health teams. A family health team is composed of a doctor, a nurse, a nursing technician, and community health workers, and sometimes other health professionals in a variable composition. Each team is responsible for the health of 2,000 to 4,000 people, depending on the socioeconomic status of the population. The more vulnerable the population, the smaller the number of individuals under the care of a family health team. In 2019, there was a major reform of the financing and organization of the Brazilian primary care called Previning Brazil, which transformed the financing that was previously mainly based on the provision of services, in the offer of services, into a mixed system of capitation, payment for performance, and incentives for specific actions, such as the use of electronic health records by the health teams, training of health human resources inside these family health teams, and expansion of the opening hours of the primary care clinics. After this very brief introduction, I will answer your questions in the formulated before. In order to have an efficient health system for the challenges of the 21st century, it's essential to start from a known population denominator, a panel of people very well defined, not only in quantitative terms, but also in the identification of each subject. Each person, both population aging, mental health, the epidemic of chronic disease, the reemerging and new challenges of infectious disease, the unfinished agenda of maternal and child conditions, the external causes, and the incorporation of preventive and healthcare technologies, among other aspects, require that the health system starts from a panel of citizens in which we have demographic and epidemiological information like risk factors, life habits, present illness, and besides that, a very well-defined personalized form of contact with each person of our country, mainly the cell phone numbers of the people. Here in Brazil, almost 9% of the population has a smartphone and could be reached by information technology. It's not enough to create a face-to-face and a virtual care network for people if we need and we want a universal health system. We need to have disease risk identification systems that allow systematic proactive actions in order to reach levels of quality of care close to the potential of each healthcare technology we have in our hands. Tracking chronic disease, such as cervical and breast cancer, for example, identifying symptomatic people or symptomatic contacts in times of pandemic, other example, are fundamental actions for the health system to be effective and efficient. And this is impossible to do in the absence of a detailed panel of people and the use of information technology. In 2018, before the primary care reform, there were 74 million Brazilians registered in the primary care digital panel at the Ministry of Health. 29 million of these 74 million were vulnerable people, vulnerable persons. And now, after the reform, we have 162 million people in this digital panel with address, with telephone, cell telephone number, with demographic aspects, with some risk factors, with some measures of lab exams. And inside these 162 million people, 62 million are very vulnerable people. The number of linked people more than doubled from 2018 to the beginning of 2022, thanks to the capitation model. The change of financing from offer of service to capitation model makes the possibility to put inside the system almost 100 million people. We had in 2018 45,000 primary care teams, and now we have 55,000 family health teams. The number of diabetes and hypertension consultations were under 30 million by year in 2019, and now will be in this year more than 4 million diabetes and hypertension consultations to this population. I think these numbers can show the importance of a capitation model and the very importance of we have a panel of people very well described and digitalized. Thank you.
Thank you, Arno. Thank you for describing the Brazil system and talking about empanelment. I'd like to move to Rifat to talk about Turkey, because Turkey has also looked at an outreach system and has also empaneled communities. Rifat, what would you say are some of the path dependencies in this journey? And a second question that I'd love for you to comment on is, when we're talking of population health, when we're talking of preventions, etc., how does a system manage performance accountability?
Thank you, Sandhya. Thank you to you and to CSCP for Center for Social and Economic Progress for inviting me to this excellent panel and very inspiring presentation by Dr. Vinod Paul and also by Erno Harsheim. So Turkey, again, path dependency is very important. Turkey has a strong tradition of public health. And when the health transformation program was introduced in 2003, subsequently, that the strong public health base was quite important in the way primary healthcare developed and evolved. So primary healthcare is very much centered around, in the new model, around family health teams in family medicine centers. And the core nucleus of the team includes a family physician, nurse, midwives, and assistants, health assistants. And in order to scale up very rapidly, Turkey, because there was no tradition of family medicine, although there was a small residency program, after an initial pilot, Turkey introduced retraining of general practitioners, doctors who were not hospital specialists or neurospecialists, and internal physicians to transition to be certified as family physicians. So that enabled rapid scale-up of the family medicine model, provided through family medicine centers. And comprehensiveness was one of the initial objectives of the system, but with a strong focus initially to improve outcomes in relation to maternal and child health. So the payment model was designed to attract teams into family medicine. And rather than just a salary-based system, a per capita payment model was introduced with some weighting and adjustment for rurality, but also socioeconomic vulnerability with higher payments for the population that was vulnerable. So family health centers are remunerated according to the number of people they cater for, and this is typically between 1,000 to 4,000. And on average, each family health center has around 3,000 persons that they cater for, with adjustments that I talked about. But there's also a performance-related pay, focused very much on the initial targets: antenatal care, immunization, and so there are negative incentives. So certain targets have got to be met in relation to antenatal care coverage, but also in relation to immunization coverage. And if these are not met, then there's a clawback from the payment. There's also contribution to the payment based on the average cost of a family healthcare center, but also if additional services are provided, for example, mobile health services, as well as consumables. Now, what was very interesting early on in the Turkish health reform was that gatekeeping was initially introduced, but then withdrawn because there was pushback from the citizens. So individuals are able to access primary health care, but they can also directly access hospitals, both Ministry of Health hospitals or university hospitals directly. Although this so-called gatekeeping does not exist, primary care utilization increased initially, according to a study that we've done, because of improved access and accessibility, because family medicine centers were rolled out throughout the country. But later on, increase in utilization was because the service quality improved and increased responsiveness to individuals improved. So this is very interesting. So gatekeeping is quite a negative term, and I think what's important is really providing high quality, person-centered care that is comprehensive, that is well coordinated, that empowers individuals, and really levels up the effectiveness and efficiency of services through their involvement at primary and community care level. Of course, primary care needs to play an important coordination role. Maybe a better term would be coordination rather than gatekeeping in that journey. But engagement of individuals in the care process and across the whole care continuum is very important. So the care should not be episodic and reactive. It should be very much focused on individual needs and managing the whole care continuum, from health education to health promotion to disease prevention, as well as management of the care process when there's an acute episode or when there is a need for providing continuing care for chronic disease, but also palliative care. Dr. Paul mentioned mental illness and cancer. Again, these are critically important. So one should think about the management of the whole care continuum rather than episodes of care. In Turkey, what's interesting is that, again, based on the earlier approach to providing primary care, was that in addition to family medicine centers, there are also community centers, community health centers. These are based in the district. They deliver community and public health services. For example, environmental health, reproductive health, child health and adolescent health services, as well as they're involved in cancer screening. So they work very much in conjunction with family medicine centers that have focused both at individual and population level care, whereas the community health centers, based on the traditional structures, provide public health centers, provide public health care. But more recently, Turkey has introduced healthy living centers. Again, this is transitioning from managing acute episodic care for acute events or disease management, actually emphasizing healthy living. And this is, again, multidisciplinary services that provides guidance in relation to management of non-communicable diseases in sort of proactive management of NCDs with the screening for priority NCD conditions to ensure that there is a population level approach with a focus on early management and management of risk factors, not just management of disease as and when it develops. Now, I could go on, but I'm conscious of the time. I'll stop there. But maybe just one important point, not just in relation to Turkey, but generally, in 2018, I was asked to develop a report for the Alma-Ata conference, the 4th year anniversary. And I undertook a very comprehensive analysis of the way primary healthcare had evolved in the WHO European region. Turkey is also in the WHO European region. That includes 52 countries. And a number of important principles emerged from the primary care models that were being developed. And each country has a slightly different flavor of primary healthcare. And there were 10 important principles that characterize primary care models that have emerged in the European region. The first was people-centeredness, holistic services emphasizing individuals rather than focusing on disease and episodes of care. Secondly, integration, integrated care, integrated provision of person-centered continuing care for individual health services, but also public health. So this dichotomy between individual service and public health should no longer exist. We should try and integrate both. They're part and parcel of the same thing. Third was important coordination role for primary health care, both management coordinating of the care process within primary care setting, but also across levels. Fourth was comprehensiveness that both Dr. Vinod Paul and Erden Harsheim also alluded to. Comprehensive for a core set of intervention across the care continuum. Fifth, and very importantly, continuity of care. So it's not just episodes of care and fragmented care. Six, a focus on not just the individual, but also the population with a sense of responsibility for health and well-being of the population, including social determinants of health. Very important. And I think Brazil has done that quite well. Seventh is participation, engagement of communities and individuals in the design, planning, implementation process. That's the only way to improve social determinants. And eighth is accountability. Ensure that the services provided are effective, evidence-based, efficient, equitable, and responsive to needs of users and the changing context. Ninth, a solid evidence base for the interventions, but also the services that are being delivered. And finally, integration of technology. All of this underpinned by use of technology to enable provision of highly targeted precision public health and precision health services for individuals.
Thank you, Rifat. Thank you. That was really a very, very comprehensive outline and much appreciated. I have a question on incentivizing performance, but I will come back to that later. Right now, Sujata, everybody's talked about the importance of a people-centered system. So my question is that in India and elsewhere, actually, for that matter, can population health be managed without the system or model of empanelment? And in India specifically, empaneling community groups. And in India specifically, how can that happen, just given how large our population is, etc.? And then the second, what I asked Rifat, again, what type of performance management mechanisms would be most effective? You're on, Sujata, you're on mute.
Thank you, Sandhya, for having me this evening. Both the previous speakers have really laid down the principles of primary healthcare, particularly Rifat has gone through the whole comprehensive definition of it by WHO. So now your question for me is very specifically oriented to community engagement. In that sense, is that what I've got you right, I hope? That you want to know people's participation, how do we do that, and what could be the performance measurements for that?
Yes.
Now, in the context of primary care, one of the articles of faith in the WHO definition concept of Alma Ata, and now again, as Rifat has said, is that primary healthcare can only be effective if it is people-centered. And what they mean by that is just not having a committee where people representatives are members of it, but it is based on the concept that the accountability of the primary healthcare system is to the people. Now, in India, what had really happened, as Dr. Vinod Paul has traced us very rapidly through the history of primary healthcare in India, ours, as you call it, a very static, passive system of primary care. And that was suitable for the communicable diseases that we had, the disease burden we had, which was episodic. So whether it's malaria, whether it's a pregnancy, whether it is HIV, whether it is TB, whether it's leprosy, these are all episodic events that happen. And therefore, the primary healthcare system was really addressing that. And it was only in HIV that a little bit of the community engagement from the key populations was required, because it was a chronic disease and it was also required a lot of behavioral change. And that then brought in the whole focus on how do we make the primary healthcare centers much more responsive to the people. And that can only come when the primary healthcare teams know what the people need. In India, we are a very diverse people. The state of Bihar cannot be Kerala. Kerala's model cannot be cut, paste, and put there. Government of India can only lay down broad principles, can lay down what is the broad vision. But ultimately, it has to be decentralized to district and below, looking at evidence and data, and which we don't have that kind of systems here in our country, because even today, the disease burden estimates are state level. We don't have it district level. Every district will have a different disease burden in our country. And therefore, the system has to be designed in accordance with what the disease burden is, which reflects in a kind what the people need from the health system. So if you go to an Assam or a Bihar where people are desperate for reproductive health care or desperate for family planning, unmet needs and so on, and you go with saying, I'll do mental health, which may not be the highest priority, which could be a high priority for Kerala, then your health system is not responding to people's needs and people don't respond to you either. So the first step for me to say, when you say people's engagement, it is to have what Turkey has done, as Brazil has done, to have population demographic and health surveys to predicate any designing of the primary healthcare system in that district, to say what should my primary healthcare system be doing in addressing these disease burdens that this particular disease has. So that lends it the accountability which is very necessary. And it's only when in such a framework can all those terms and concepts and principles that Rifat has laid out, continuity of care, comprehensiveness of care, need-based care, all this comes in when the team leader, when the family health team is given a dedicated population that he's accountable for and is able to say, in my group of dedicated population, that could be in India's context, maybe 2,000 families, 10,000 population, or as in Brazil's concept, about 5,000 people, which is 1,000 families. They know that there are so many elderly people, so many who have required reproductive needs, so many are hypertensive, so many are diabetic. And this then becomes the target, the performance by which you assess the family health team, whether they're really addressing the people's needs and bringing them to a level where they are healthy and well. So what I see is India's history, if you really take a snapshot of 75 years, today, what India is struggling with is making this transition from a very passive, episodic health system to a system which can give you the continuity of care, can do chronic management. Diabetes and hypertension is not an episodic event, it's a lifelong event. So the health system has to have that ability. The family health teams have to have the resilience. The primary health care has to be oriented to follow up that diabetic case day after day, week after week, month after month, talking to him, going to his home, bringing in health, that behavior change in him. There's no point giving him a drug if that guy continues to eat irresponsibly, not do exercise. So the lifestyle changes, the behavior changes have to be brought in, and he has to be pursued. A hypertensive gets, a heart ailment or something, you do post-hospitalization care. So this kind of continuity of care, which means the whole mindset has to be changed of our personnel who are working in the primary healthcare system, which requires new skills and competencies is one aspect, but massive retraining of our people to say that you are accountable to the patient, you are accountable to the people. So population health in terms of behavior change for healthy life. I mean, I'm not saying yoga is one aspect, but more importantly, look at the diets that we have, how much of rice we eat. So our eating habits, our exercise habits, bring in changes in the laws of making available, like Chandigarh, I would say, is a healthy city. Those kind of environments have to be created. And so and to that extent, the toilet program, the water sanitation initiatives are bound to have a massive impact on our diarrheal cases and infants dying of diarrhea. No doubt about that. But beyond social determinants, at the individual family level, we need to do a lot more counseling on behavior change. And that becomes people-centered because the health team takes accountability for that particular family under his charge over a period of time. And that's easier said than done. This requires a long-term vision. It requires very systematic and properly sequenced reforms. It doesn't mean just planting somebody here or putting 2 doctors or 3 doctors. That doesn't help. Each team, ability to work in teams, which also means that you have to probably change your medical education, bringing in the kind of change that was envisioned a few years ago to say who wants to do clinical medicine, who wants to go into community and public health. So these kind of specializations will need to be thought of today. Whether it's family medicine, whether it's public health. So these disciplines need to be brought into the primary healthcare space. So I say when people get automatically engaged if they find that particular health center, whether it's a sub-center or a primary healthcare center, responding to their needs. And you can actually see the difference of this approach when applied in Kerala. Few years ago, Kerala had barely 1 patient coming to the primary healthcare center. Even I, as a secretary, when I visited Kerala many times, I used to think maybe the sub-center and the PHCs in Kerala setting is a waste of money. And because everybody in Kerala goes to a hospital. They all want to go to the district hospital. They're not interested in your sub-center PHC. But I was wrong. Now they have implemented the family health centers, as they call them, family health centers, 550 of them, where they can even get nebulizers and asthma drugs. It is the amount of intensive training of existing teams with changes in functions and responsibilities have been changed. And with that, you should see the footfalls today. It's massively increased very substantially. Now, Tamil Nadu is also doing this population demographic and disease burden surveys. I think that's the way to go. I think we need to look at India not as one homogeneous unit. We need to look at North very differently to the South. And we cannot ask any state to say, please wait till the other state catches up with you. Because for, say, a state like Kerala, diabetes and mental health and hypertension are very, very critical. RCH is not so. Whereas for a UP or a Bihar, RCH still continues to be a very, very critical need. So, there are 2 epidemiological worlds, and the health system has to be addressed to reflect that. So I really look forward to furthering the reform process, which Dr. Vinod Paul has so nicely laid out. to say, let the next stage be towards decentralization, towards gathering more district level data, preparing teams to work on the evidence and tuning their own health systems at the district level. And I believe, Sandhya, very strongly that one feeling, and I felt it even when I was in service, that we have no patience. We don't have the patience to do piloting. But I've seen the efficacy of pilots, both in the HIV program, where DFID supported us immensely on pilots, which then, as you know, Gates Foundation came with big money, and NACO also scaled up with a huge amount of money, and we were able to scale up those initiatives. Kerala also did that quietly for 2014 to 2016. For 2 years, they worked this model only in 3 PHCs. And now, despite COVID, they've been able to upscale it from 3 PHCs to 550 PHCs. So this kind of modeling has to be done at the micro level, because that is where it counts. The broad vision at the national level cannot ever be replacing the local skills and the local solutions that the teams at the local level have to bring in. I'm not sure if I've answered your question of people-centered, but I do believe that the people-centeredness comes in only when the health system recognizes them as important key stakeholders.
Yeah, no, you have, Sujata. Thank you so much. And I'm going to take off from your focus on teams, that in order for a system to be people-centered, the teams that are working on the ground have to have a variety of skills. And because they're there for the long haul, it's not that sporadic engagement. So they're really, in many ways, the fulcrum of an effective primary care system. So I'm now going to ask a question on the workforce, actually, where the whole schedule has gone a little haywire. That's okay. So I had a question on workforce and one on financing, but I'm going to mix them up if you don't mind. I'm going to go to Rifat and ask, so Turkey has multidisciplinary teams. And as all of you have said, that it is very important to have teams which can do both outreach and curative tasks, and on a variety of issues, communicable, non-communicable, population health, etc., etc. The key element of something like this is skilling, training and skilling these teams. Rifat, would you talk about Turkey's journey in terms of skilling? Because I'm just thinking, again, of large countries, India and others, that often becomes a bit of a bottleneck. How do you actually manage effective skilling? Of course, the numbers are a big problem as well. But since we are not necessarily talking of medicalized teams, let's assume for a minute that numbers are not such a challenge. So Rifat, would you talk about training and skilling, and in about 5 minutes, if you could?
Absolutely, that's a really critical question. And I think there are 2 important dimensions to that. So the one is the temporal dimension, and the second is the sort of the scope of scope and scale of the skills. Now, temporal dimension is important because in any reform program, one has to scale up rapidly to introduce nationwide changes. Of course, very important to pilot to understand what a model might look like. And I would even go beyond calling these pilots. I would call them demonstration programs to show what the new would look like. Because what's on paper, when it hits the ground, is going to be very different. So one can spend years designing the perfect solution informed by technical evidence. But actually, when this solution on paper hits the ground, it's going to be very different. So it's very important to demonstrate what could work and then scale up rapidly. And Sujata used a very important word, staging, sequencing and staging is very important. So it would be very important to have a core set of skills and competencies for the team that enables a rapid scale up, because one has to show results, to show impact of these interventions, to get buy-in, to get legitimacy, because one is introducing a new model. And with anything new, there will be pushback because people will not want to change what they're doing. So that deciding what is the initial core set of skills and competencies for the primary healthcare team is a very important exercise. And then thinking about looking at the available workforce, which will be different from state to state, municipality to municipality, who needs to be trained so that everyone's leveled up to have this core set. So that's the temporal dimension. Then the second element of temporal dimension is over the longer term, what kind of skills and competencies need to be in place, what is the scope of these skills, and what is the scale of these skills to enable a country to develop a larger set of services. So in Turkey, there was an emphasis initially to rapidly scale up skills of doctors and nurses to make them, to enable them to become members of a family health team. And this included short course training over 3 months. And initially these courses were piloted, and it was shown that the training program was successful. I was actually involved in the design, but also in the evaluation of these. And then from 3 provinces, the program was rolled out to 81 provinces very rapidly. And that was instrumental in demonstrating that the new model would work and actually achieve results, which then gave the Ministry of Health and the government the legitimacy to continue with the changes. And the initial emphasis was on developing this nucleus of family physicians, family health nurses, midwives, as well as assistants. But of course, as I said earlier, there has been an expansion of what is provided in healthcare by extending population-level public health interventions through community health centers and now through healthy living centers. So I would work backwards and say, where do we want to be in 10 years' time? And my vision of primary care is that primary healthcare should be providing 95 to 98% of all healthcare-related episodes. We cannot solve health problems in hospitals. That is just not possible or feasible. So primary care, and we're very fortunate to have technology in terms of diagnostics, remote care, in terms of treatments, and health technologies that will enable us to provide really high quality and comprehensive care at primary care level. And the skills and competences should be coupled with that vision. Primary care shouldn't be the weak, basic care that has characterized primary care. It should be the core of the health system, providing the best services and attracting the best members of health professionals. And I think investing in nursing and other cadres are actually a really wise decision, because chronic disease management has to be managed not just by doctors, but actually by nurses and other healthcare professionals. So work backwards from what is the vision in 10 years' time? This is an ongoing process, a changing process. And then gradually build these skills and competences. But think of the temporal issue, rapid scale up with a core set of skills. So everywhere we have these services provided, and we have the platforms to build upon.
Thank you, Rifat. I'm tempted to move on to financing. And Erno, you had talked about Brazil being a decentralized system and how the municipalities control large part of resources. Could you talk about Brazil's experience in how did the decentralized process impact delivery of primary care? And also, I'm tempted to say more importantly, what was the politics around that, around being able to decentralize resources?
Okay. How I talk to you, the municipalities are the responsibles to provide primary care in Brazil. And they receive the money, they receive orientation about the composition of the team, which is not the best way to do it, but they receive from the Ministry of Health a list of activities, a very comprehensive activities, actions they have to hold on to, maintain and turn better the health of the population. It's very important to talk about the nature of the reform of the financing of the primary care in Brazil. I think one of the first things to talk about is not about the nature of the provider. I agree a lot with Professor Rifata too, that we need to looking for the needs of the population, and the list of actions, activities the team will hold on with the people will change over the years. And primary care has to be a very technological health services. With this increase in information technology and other technologies of healthcare, we have to put technology in the healthcare primary care teams. For that, many times you need to need help to the private providers of health in each country. And I think the nature of this provider, if the provider is public or private, it doesn't matter. What really matters is the quality and the nature of the contract the government have with each provider and the method of payment between the government and the provider. OECD has established that the best model for pay for primary care is a mixed model in which 50% is capitation and the rest is divided between incentives, a little bit of fee for service, and pay for performance. Capitation has to look in for equity. That is, capitation should pay more money for each individual who has the greatest needs. And the pay for performance must be based on indicators inspired by the value-based healthcare, with indicator representing health and not only illness, as we have talked a little bit more now. Here in Brazil, we will have 21 health indicators for the pay for performance of our reform. 4 of these 21 indicators are health indicators, are the resolutivity of the doctors, the scores in primary care assessment tool, an instrument developed by Barbara Starfield, who measures the quality and the presence of the attributes of primary care, PDR-K9, an instrument developed in Holland that measures the strength of the doctor-patient relationship, and Net Promoter Score, a very useful marketing indicator of compliance between people and services. The other 17 indicators are directed to illness that are important here in Brazil at this moment. Diabetes, mental health, hypertension, immunization, maternal and child care, HIV, tuberculosis, and they try to move from structure and process indicators to result indicators. But the challenge in this changing process to achieve these better results indicators is the information we have to measure it. In Brazil, at this moment, we put more or less $4 billion annually from the federal budget in primary care. This represents 17% of the federal budget for health. It's decentralized to the municipalities, but the municipalities put out of their pockets more than the double of a little bit, 1.5 numbers of this, like $6 billion annually is put in primary care from the pocket of the municipalities. We have a $10 billion budget to primary care here in Brazil, to this 150 million people, representing more or less $50 per capita a year, and 40% of this is from federal government and 6% of this is from the municipalities. So each city, each municipality has some orientations from the federal government, but they have a lot of autonomy to looking for the needs of their population and try to conform and offer primary care teams to resolve these problems. The problem of this radical decentralization is that we have more or less 1,000 cities, very small, with less than 5,000 people living there. And these small cities, they have some very weakness to make governance in health. So we need a role of the provinces, of the states, to take the hand of these small cities and make possible to have a better primary care. As a national health system, there are no formal out-of-pocket costs for the citizens in Brazil. But Edson Araújo and the World Bank showed in a recent study that about 20%, 12% of the household budget is directed for healthcare here in Brazil. And in the poorest decile of income in Brazil, this 12%, 84% of this is spent on medicines. And we have a free medicine program offered from the municipalities and from the federal government. It shows, Sandia, that we have a national health system, but with a lot of challenges that we have to work to become it better. Brazil spends about 9.5% of GDP on health, and of the whole of GDP, 4 to 4.5% is to the public system, and 5% of the GDP finances the private system. And the private system has already some incentives, tax incentives, in the order of $3.5 billion a year. So we have a disequilibrium in the financial of the private and public sector in Brazil, and a lot of space for additional reforms. And I think it's important to talk to you some of the main lessons we learned held in the primary healthcare reform in Brazil. And I think this goes in three directions. First of all, it's only possible to reform financial if the proposed reform meets some of the provider expectations, mainly the absolute increase in the value, in the amount of money we are transferring to the municipalities. We spend more than 10% of the primary care budget in the first year of the reform. Second, the reform has to be widely discussed with the providers and undergo changes in response to their demands, as long as this change does not mischaracterize the nature of the reform, and have to present very clear transition roles. A radical reform, it's impossible to make it without transition roles. And third, to be carried out and to achieve stability, a reform in the financial of primary care should be made with a lot of transparency and accountability. All of you were talking about accountability, inclusive to produce a healthcare system more accountable and more responsible with the public budget.
Thank you, Arno. That was a really, really interesting and useful outline of many of the financing elements. In fact, as you were speaking, I had so many questions, but we are so behind time that I think we'll have to have a follow-up discussion on this. I'm going to ask one last question of Sujata. Sujata, if you could just take 5 minutes. Many countries like India have a very large private sector. Arno talked about the importance of contracting, and whether that be to the private or the public, it doesn't matter. My question to you is, can the government, or how can the government shape the private sector through contracting mechanisms in the context of primary care specifically?
Well, you know, to begin with, I think as a nation and as a policy, we must admit to ourselves that of the three sectors, tertiary, secondary, and primary care is something that cannot be left to the private sector. It has to be done by the government. And what do I mean by that? That is that government alone need not be providing the services. Government can also take private sector people to provide the services, but then, like I really have a lot of confidence in the way in which UK has done its GP system. And as you know, all the GPs there are private people. but they're very tightly bound by the government, both in terms of they cannot earn a pound more than what the government gives them. And they're accountable and answerable to the government for the services for which they're being paid. So, if we can have a private sector provider who is who's allowed to do or is asked to do this package of service delivery and is fully paid for and doesn't have his own side business of any kind, that's okay. If that's fine. But in our country, because of the lack of, the proliferation of the private sector has been so mismanaged, if I may say so, that on the same street, you'll have a Jola fellow, you'll have a RMP, unqualified quack, so there are a lot of holes in the bucket, which it becomes very difficult for the government to plug and have a neat system to say, for these 3,000 population, Mr. So-and-so, you are going to be with your team, the responsible, and I contract you for that person, for that service delivery to be done to these 3,000. It's the primary healthcare scene in India is very complex, very multivariegated, very competitive, and it's very difficult for government to be finding space and providing the delivery of services on its own. This is the reason why contracting in the primary healthcare system is becoming very, very difficult, because accountability and performance of the private sector to the contracts that they have agreed to is very complex and very difficult. So this is where I think the redesigning has to be done. For example, if we can restrict the private contracting only to, say, missionary hospitals and not-for-profit. And what do I mean by that? In a tribal area, it may not be the government may not be the strongest actor to provide services in the remote and tribal settings. Maybe there's already a missionary hospital. Like in Bastar, there is the Ramakrishna Mission, which is the only source of providing services to that lot of people. There's no harm in government getting into a contract with them, saying these are all the services. We give you money. We also give you the drugs that are required for you to give under the national health programs. But we will extend the contract severely on a third-party evaluation that you've really immunized all the 100% immunization, 100% of antenatal care, whatever the contract lays down in terms of services. But, so this much, we should go step by step. Can the government say, identify where its source of strength is, where are its strong senses, where they can provide the private sector, the primary care services through its own centers, and where do we need to co-opt or partner with a not-for-profit, charitable, missionary, whatever, charitable organizations that don't do for profit, but then make them strictly accountable to have the team that we specify, providing the services that we lay down, and have a system of evaluations concurrently, frequently, to see that they're giving the quality of care that we want to give. I know Rifat should have mentioned,
yes.
He knows that in the to arrest the reproductive health care, they had a whole lot of these nurses, midwives in every village who could charge the patients, but they were giving safe and good quality reproductive health care in that particular locality. So, you can experiment with all that, but the payment system has to be public. And for that, we need to increase our budgets. And since this is the last question, Sandhya, I would only like to say, no matter what vision we have, what concepts and principles we may adhere to, the overall budget has to increase. In fact, the Economic Advisory Council of the Prime Minister set up a task force in 2019, and they made a report of what is required for primary care. And that itself came up that for infrastructure strengthening, as per the IPHS standards of 2012, not 2022, which are way beyond our capacity for the next 50 years, 2012 IPH standards, they need 1% of GDP, and human resources requires another 1% of GDP. Now, 2012 IPH standards were very modest, and even to achieve that modest safeguards standards, we need a 2% GDP to be dedicated to the primary healthcare system. So, these are complex issues. Ultimately, what we need is a step up of public investment. And if we can focus it on primary healthcare, public, private, I don't care who the provider is, but quality, the service delivery, the evaluation systems, and ability to not allow it to get politicized and really have an evidence-based driven system that will help. But I think, but then that requires a very solid regulatory system in our own country. So it's a very interlinked, mixed up set of issues that we need to deal and layer by layer tease out and sort out to achieve that end.
Thank you, Sujata. That's very well put. The need to increase budgets, the importance of government being responsible. The provider could be public or private, but figuring out how to tackle our very, very heterogeneous non-government provider landscape, whether it be for profit, not for profit. But as you said, it is a very heterogeneous landscape. They're there. It is important to leverage them somehow, but not entirely clear how. Now,
may I, if I may, Sandhya, just
yes.
30 seconds, just to, I mean,
Sure.
I practiced as a family physician in the UK for many years. And, you know, we're independent contractors. There was a service, we were contracted, and we provided the service, but we're part of the national health system.
Right.
So I think it's very important in this phase of reforms to use all the assets available.
Yeah.
And in terms of assets,
Yes.
I mean the human resources available
Correct.
to scale up the reforms using contracting, but very importantly, having defined the skills and competences to have licensing and ongoing accreditation and ongoing performance measurement.
Yes,
But
that's
one
right.
should contract with public sector providers as well as private
That's
and
right.
not-for-profit
Right.
to
Correct.
scale up, to level up services across the country, then build on using contracting as an instrument to
Absolutely.
expand the services and to introduce performance-related pay.
Absolutely. Thank you, Rifat.
Yeah,
Very, very
Professor
helpful.
Rifat, is
He's
this the
put it well.
model we have to follow? We have to be worried about the nature of the services provided, not the nature of the provider.
Yeah.
Exactly,
Correct.
Yes.
and focusing on the outcomes,
Yeah.
not just
Outcomes.
inputs.
Yes,
Absolutely.
quality and outcomes.
So on
Indeed.
that note, I'm going to now come to Dr. Vinod Paul, because in fact, as Sujata was speaking about the need to raise more resources, I thought that's a perfect point to actually pivot back to Dr. Paul. So having heard, all of these insights and experiences, Dr. Paul, over to you, just in terms of how you see some of what you heard. And maybe
Just Sandhya, just before Dr. Paul starts, I'd just like to say that in the scale where we are, money is important.
Yeah.
But I think more than the money, I mean, if the Prime Minister says, Dr. Paul, you want, okay, here, take the 3% GDP, I think he will probably sink with tension. Because, first we have to get the design and the whole fit right, which requires a lot of baby steps of reform and clarity of ideas. So then the money follows and you can really scale it up. Sorry, I just wanted to say, but because in our discourse in India is constantly badgering government, money, 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 but money for what?
Yeah, fair point. So Dr. Paul, your thoughts now.
Thank you very much. Very illuminating discourse. It's wonderful, insightful presentations and comments and new information. So thank you so much, ma'am and Dr. Rifat, and very, very grateful. Well, I think the points that have been made and summed up in the last 3-4 minutes with enthusiasm are absolutely valid, and they provide taking the discussion forward for the kind of work that policy enablers would do. So it's very, very insightful. It's refreshing because in COVID, several missions had to wait, and I'm glad that we are reigniting our broad discussion around the health system. Having said that, I think my one takeaway is the word continuity of care. I must say that we haven't used that very often, but that has come very strongly, episodic care versus continuous care, and therefore a responsibility of ensuring compliance, ensuring follow-ups, ensuring outcomes and change in the status of health uh, over and over again over weeks and months. So something which is very well stated, extremely well stated. And that also has become part of our training, because often our training is a snapshot training. We don't follow enough in our training. So that is something very, very refreshing. Second point is that we still are struggling with an optimum model for, or models for, urban primary healthcare. And some of the insights that I heard today, refreshingly as they are reminders of looking at some doing urban healthcare, urban primary healthcare somewhat differently from the rural. Is putting something very big issue into a very simple 2 sentences, but I think that's where there is a room for innovation, room for not simply to cut paste the rural model, to say the least. And surely, I think because that work is still to unfold, as we know. We do believe that we should give leadership to the local self-governments, especially when the urban geography and population is, say, of size something like 500,000, 1 million, in that range. The rural model tends to then break down because there's too much of complexity around it. So one take-home message is that surely for urban, think about different models. The point about contracting, the very fundamental problem that we face at the moment is we don't have enough people to contract in. Who will go to whom do we contract? Even if we wish to hand over services of a geography to a private system, but where are the private providers of the kind and mix that we would like to have? So that's a constraint that we have to live with for some time. But certainly in the urban space, some leeway and some flexibility is available to us. My third point is technology that can leapfrog many steps and gives us an opportunity. For India, technology being relatively strong and rising, and in being utilized as well in the health sector and several other sectors, there is a huge opportunity for us to tweak the approach using technology. So the core principles that you all have said remain the same. Rifat, you highlighted them very, very clearly. But in order to reach and to embrace those principles and to practice those principles, technology could come handy. I just want to add here that in the health and wellness centers, having telemedicine is a norm. Telemedicine has to be there, using a smartphone or using a static computer. It is a norm, period. And I have a number here to just impress you. 46 million consultations through these emerging health and wellness centers till date. And that's being tracked. So technology, and then as I mentioned to you, the health accounts, health ID and digital health records. So some of those approaches could be taken forward and be leapfrogged using technology. And I think that's an opportunity that we are looking forward to. Talking about data also, it is possible for us to leapfrog in terms of local data and its utilization using technology. So that gives a huge opportunity. And your ideas on how technology can be leveraged for a situation like ours, and ma'am, your thoughts connecting to practical domain, Madam Sujata, would be very useful as we take this course forward. I think clearly primary healthcare must remain the most important component, foundation of India's health system. There is absolutely no doubt. We wish to move in that direction. I think the quantum improvements that have been carried out since 2018 are one very major change and transformation, but a lot more has to happen, must happen. And particularly in the urban space, I would say learning is still underway before we finally talk about one design or more than one design and how to go forward. But very, very kind of you to have me into this discussion, and excellent learning. Thank you indeed.
Thank you so much, Dr. Paul. Thank you for outlining some of the key elements that came out of this conversation, some that need attention, as you said, urban PHCs, continuity of care, etc. Others that we know they're already underway and can help leapfrog, like technology, data.
One question, one thing we are grappling with is the care of the elderly. So if there are ideas on, how to orchestrate care of the elderly in the rural system, compatible with the rural, imperatives, those ideas would be very welcome. Research, pilots, demonstration projects would be extremely useful from the global learning.
Absolutely, absolutely. Thank you, Dr. Paul. So care of elderly, a learning ecosystem, focus on data, using technology to leapfrog, contracting, but you said where other providers, the kind that we need them, leadership to local self-government, urban PHCs, continuity of care, all key issues that need more and more attention. So with that, thanks all of you. There are a bunch of questions, but we are beyond time now, and I know some of you need to leave because I've been getting messages. So I am not going to take questions. I'm very sorry. My apologies to the audience. I could take one or two, but that's unfair. Either we take the bulk of them or none. We'll see if there is a way to get responses to these questions from our speakers later. But my profuse apologies that time is not allowing us to take questions. But thank you so much on behalf of CSEP for this very rich and enlightening discussion. We hope to continue our work on these issues and to reach out to all of you again. Thank you, Dr. Paul. Thank you, Sujata. Thank you, Arno. Thank you, Rifat. Thank you very much. Good night. And thank you to all of our participants who listened, who contributed with their questions. My apologies once again.
Thank you very much. Thank you.
Goodbye.